Okay, so in the United States, right now, cochlear implantation is not an approved indication for adults that are 65 years of age or up that are covered by Medicare. And so there are currently some movements underway to try to convince Medicare that this is important for this patient population. And we have two patient populations that we have reviewed and published on, two separate groups, which is important to consider, but in that, the major finding was that yes, the outcomes may not be the same as they are for younger adults. However, these individuals experience a significant benefit relative to how they were doing preoperatively or in an unaided condition. And so it's really important to, instead of just saying, well, they're not as good as a 20-year-old, well, they are also experiencing a benefit from cochlear implant use. And so these are data that we are using to try to convince Medicare to change indications in our country. And this is a conversation that we have with our patients is, you can look at these publications, many of them come in very well informed, and you can see these changes in performance that are happening, but we really need to think about what your abilities are, what your concerns are, and the potential benefit that you could get from this device. The other thing that has changed recently in our practice is all adult cochlear implant recipients, and children as well, but this talk is on older adults, are referred for oral rehabilitation, and they have two options that can either be in person or virtual, and our older adults do thrive with that in-person activity more so than the virtual. We have a mini mental state examination that is completed preoperatively for all of our patients, and that facilitates a discussion of when we have poor cognition of how to involve families and support networks to best support these patients and their outcomes post-operatively. And then the HearCare app has been useful, particularly for those that are in an assisted living condition or cannot travel easily to the clinic and or provide appropriate feedback about how they're doing with their cochlear implant or how their cochlear implant sounds, because you can make some assessments of the internal and external function from that. So these are the major things that we're thinking about for counseling for older adults with single-sided deafness.
You mentioned, back to this slide, you mentioned the setup you're having now with the HearCare app and etc. So I was just wondering, with what specifically in the elderly patients you find are different when dealing with younger patients?
So these apps have only recently become available in the U.S., but particularly for our older adults, it's helpful when we cannot get feedback from them. So if we need to measure something with the internal, see what's happening with the external, see what functions or listening situations that they're in. Are they just sitting at home in a very quiet environment? Are they in a noisier environment? That helps to facilitate some of the discussions and counseling of what realistically they should be doing with their device.
Yeah. And are there do you also look into the whole social side? Where they're embedded in, what the family is like, etc. Is that an important factor?
Yeah.
Or?
So those are conversations that are happening preoperatively. So, who's coming with them to the appointment? How long did it take them to get there? What's reasonable to bring them back? Are they able to drive on their own? How far away from the clinic are they? What sort of resources do they have at home? All of those are conversations that are happening. Now, for somebody who is, who has single-sided deafness, it's a little bit different than our patients that have bilateral deafness, because now you have somebody who has a functional ear. So they're still able to be independent, but now we're focused on developing their binaural hearing or reintroducing that binaural hearing ability. So there's discussions of needing to wear it routinely. Can they change the batteries? Those sorts of things.
Yeah. Cognition is becoming an important issue in this population. Now, Dayse, down under, how do you assess that element in these elderly patients? Obviously, Frank Lynn's studies have shown, great impact, the potential benefit, or in dementia, impact on depression in these patients. So is it part of your standard assessment and counseling when?
Yeah, definitely. We have implemented using the high MOCA, so it's the MOCA for hearing impaired. We have implemented this now for a few years, and it's definitely part of not only for elderly per se, because we are doing this from 55 older and older, for all patients, regardless if it's single-side deafness or bilateral deafness.
Mm-hmm. Rudolf, in Germany, do you have a different approach, or how do you use similar tools? Or?
Of course, it is important to have the family involved in the elder people. And of course, if you have an appointment with a patient, it is always advisable to have some family members with you, otherwise it makes no sense. And the time factor has also to be included, because it needs much more time in this population than in other situations.
Lee, how about you?
Thank you, Gunesh. For China, the situation is different. If I was 3 years ago, all of the patients belongs to the children. But now, the situation different. Adults maybe occupied more than 60%. But the challenge for Chinese doctors or audiologists, how can we evaluate the physiological for the adult patient, but also we should care the mental problems? That after cochlear implant, can we get the best results for them? So we began to learn this, how to balance this, how to evaluate this. Maybe we can learn something from you guys. Thank you.
Thank you.
So first of all, I'd like to thank Professor Simon for this wonderful conference and this amazing place. So my topic will be today the etiology, and it was a lot of presentation about etiology. So I will try to summarize the information. So which specific etiologies require fundamentally more intensive counseling and why? So why etiology matters? So first of all, it's expected rehabilitation outcomes and potential medical and technical risks, and the psychological and social dynamics we should keep in mind also. So let's look at these points in more detail. So what about expected rehabilitation outcomes? They depend on neural plasticity, of course, and the integrity of the auditory nerve and central pathways varies greatly of etiology. So, for example, if we have the case for example, GJB2 of the S-cochlear nerve deficiency, or post-meningitis case, the outcomes will be different. So, and of course, the parents in progress, so a child with, for example, stable connexin 26 deafness will follow a different learning curve compared, for example, with a CMV patient. So we need to take into consideration the potential medical risks. It's, of course, the surgical consideration. There's etiologies like cochlear otosclerosis and malformation we should discuss with the patients, like gusher, difficult electrode insertion, and also comorbidities. So what about the psychological? So the patient family narrative, the story behind the deafness. So sudden, for example, vs. progressive, the acquired deafness, it profoundly affects the psychological state, and we should talk about this with our patients. And the truly informed consent is impossible without understanding the etiologically specific prognosis. So understanding the etiology allows us to build a long-term realistic rehabilitation pathway, preventing disappointment and crisis. So, I'm sorry, I was preparing like the etiology, so it's congenital. I will pass this. And if we're talking about postlingual deafness, the common etiology will be idiopathic sudden sensorineural hearing loss, viral infection, for example, COVID, ototoxicity, and trauma. So, and why intensive counseling is critical. So the psychological trauma, we should don't forget about that. So loss of the connection to the world leads to anxiety, depression, and social isolation. It will decrease the motivation for rehabilitation process of our patients. And also very important is unrealistic expectations. So the hope for return to normal, lack of understanding that the brain must relearn to hear with cochlear implant. So intensive counseling is not about more information. It's about managing expectations, setting realistic goals, empathy, and psychological support, and building a long partnership with the patients and with his family or her family. And our role is not to be just surgeons, but also partners in this complex journey. Thank you.
Thank you, Sima. So I think you've shown up rightly how etiology has an impact, the different dimensions. And so I've brought up the slide. This is sort of the query we had in the audience. As you can see, I brought up a few diagnoses where we consider single-sided deafness CI, and on top it looks like counseling for single-sided deafness after vestibular schwannoma surgery seems to be the most challenging entity. Do you concur with that, or do you have is something else more challenging in your everyday life? I mean, this is, for us surgeons, like Rudolf as a surgeon, Sima, but Megan, Dayse, and Li again as a surgeon. Do you have different perceptions, or does it reflect what you see here? What your challenges are in counseling these patients with these pathologies? Rudolf, please.
Of course, in vestibular schwannoma after surgery, if there's a deafness, it's really difficult to decide. And it's only possible if you are involved in that type of surgery, if you know if, for example, the cochlear nerve is preserved. And if you have no information on this, then it's really difficult to counsel the patient in a reasonable way. So I can understand why this is at the front of the list here.
Sima?
I think we have some quite the same percentage of the etiology. But the problem is that in Russia, the single-sided deafness is not paid by the government.
The reimbursement challenge.
Yes, and that's why I think we have not so much cases to have a real statistic.
Yeah, I think that probably we would agree, particularly, and if we go to the second one, a congenital, if we think about if it is children, if it is adults, so we add another complexity to the picture there. So, I would agree with what the audience has voted there.
If I could just build on that point, I think what's really interesting right now are adults that have lost hearing later in life, but it's been 40 years. And I think we're all still a little bit nervous, but we've seen a lot of success in that patient population. So they're a little bit different, and it's interesting to counsel that group because it seems very unknown of what that outcome will be. But if we lean back on our data from patients with bilateral severe profound hearing loss, we know 40 years of deafness, the outcome is not going to be as great. But for the single-sided deafness case, it makes the preoperative counseling a little different.
So that's I know in the early, the late 2000s or early 2000s, the age of onset is the question. In these patients, they come in several decades. I remember in Perth we did a trial, Dayse, where we looked at these long-term deafness duration, and you're right. They get there. They probably take a bit longer, but they get there. So has your assessment and counseling changed specifically in these patients when they come in? They say, I've lost my hearing when I was in primary school or something like that, right?
Now, primary school, maybe not, but, somebody that lost their hearing in their 30s or 40s and they're now in their 60s or 70s, that's a different conversation. And when we designed our clinical trial, we said 10 years duration of deafness, because that's what we had always known, is that 10-year mark.
Yeah.
And then the FDA reviewed our data, and that's unfortunately the criteria, or one of the criteria that stuck, is this 10 years. And now we've seen patients with longer durations of single-sided deafness that are doing very well with their cochlear implant. And so now we're needing to show that data to make more changes.
Lee, for you?
Thank you.
Yeah.
So,
Do you can you in China do the implants also after vestibular schwannoma surgery? Is it the reimbursement always is a challenge? Like Sima said, in Russia, it is a challenge. Is that the same issue in China as well?
the situation is different. In China, the policy is changed. Chinese government can cover this for our patients, so the price low down. And also for single-sided deafness, the insurance company will cover everything for this. So why too many adults try to select cochlear implant surgery? Because the price is low and the insurance company cover everything. So for single deafness surgery, it's more common than before. But for the tumor, for the first one selections, if the tumor removed in our center, we have this ability to preserve the residual cochlear nerve. After this, we can do cochlear implant simultaneously or sequentially. But for the patient, remove the tumor in different hospital, then move to our hospital to receive cochlear implant, we should vary a lot. We did a lot, but part of them, no any kind of response 1 year later. Maybe they destroyed the nerve.
Yeah.
But selection 2, for congenital, the problem is for very young children. They suffered from CND and also single-sided deafness. Is that a candidate for cochlear implant? We know American FDA, they show that you should not touch this. But
So you mean for cochlear nerve dysplasia and single? Yes. So
we do not know
because of
how
the
to
outcomes.
selections.
Yes. Yeah.
Thank you.
Yeah.
Okay. So I was given very clear instructions, five slides, 5 minutes. So let's see if I can keep that. Well, my question was, the question that was given was, what is your 3 key resources that we use? And I find quite difficult to put it together. So put 3 here. I hope that we are in agreement. So my number 1 is education. I think that has been, this morning has been brought many times already in terms of the education, that this knowledge that we need to have ourselves and also pass on to the patient to help them to make that decision. So it's a knowledge that is not based only on clinical experience, but based on evidence. I think that is very important that the patient knows the research that we are doing, what the results that we are achieving, to help them to actually set the goals, make that decision appropriately. We are never going to be able to get 100% patients, the right patients, but I think that it has helped in our center to get the right patient and the right outcome, particularly when we are talking about single-sided deafness. So I put it there. For me, knowledge is the first resource. So this education, this very high-level education to the patient, helping them to set their expectation clearly. I just put on the screen one thing that we adapted in our center when we are helping patients to make the decision, to make an informed decision. So these are all the topics that actually we cover with each patient and actually showing them what are the evidences out there to support their decision. So number 2 is related to cognition and oral rehabilitation plan, right? I think that for this, what I'm trying to say is what is the patient bringing? What is their cognition ability? How long have they been deaf in terms of what is the neuroplasticity possible with this population? Depends on the duration of deafness, depending on the etiology. What are actually they are bringing to the table that we are going to be able to work with? And of course, to plan the rehab, right? Because the rehab has to be specific. is specific for the patient, but also take into account how they can work, their age, what is the material that we're going to use, what is their reality, as Meg said before. Do we need to prepare something that is to do at home? Is that a face-to-face? Is that a group therapy? Is that a virtual clinic? So I think that we need to take all of that. So that's my toolkit number 2. So it's training the brain to hear again, right? So that is probably the bottom line. The toolkit number 3 for us is and has been discussed several times already, is this psychosocial support. It's not only the patient, it's not just the ear that we are working on, but their social environment as well. So, and this again has to be tailored for the patient, right? Is that a one-on-one? Is that a small group? Is that a full support in terms of network, peer help? So all of this put it together. So, and this is what is going to happen, these patients in the long term. I think that we have been seeing more and more. I'm kind of like battling between bilateral deafness, single-side deafness. I think that everything is here is for both, but for the single-side deafness, it's very important that they don't become a non-user. So that is the summary: education, rehabilitation, and support.
Thank you. So these are 3 important areas. I think that's been reflected, quite a few times, as you said. Do you actually have toolkits for this, or is that something you've conjured up, created yourself?
Sorry, Ganesh, what is the question again? I was a little bit distracted.
You're talking about toolkits, which is great. If you have, so do you have tools, or what are the tools you have for them, or did you have to create them?
We created them as a team, so this is something that we have been working on. We have speech pathology and psychology in our group, and actually we have created really toolkits that's actually personalized. And even our rehab auditory training is actually personalized for the patient, and we work with them before the decision making. And it's part of the decision making. Are you willing to? And you have to sign this piece of paper saying that I'm willing, I understand the process, I have chosen this implant because of this, and I'm willing to put the time and the effort into the rehab.
Yeah. Sima, counseling, as surgeons, counseling patients, what do you do differently as a surgeon? If it's a patient with bilateral deafness who comes in for a cochlear implant, and a patient for single-sided deafness, how do you approach it? What's different?
So the main thing that patient is waiting for normal hearing, like the normal side. And I think that's the main goal, is to describe that it will be not like that, and especially the first months. And this is crucial because especially adults, they're getting really depressed. It's a big psychological problem, because I thought it will be like it was before, for example. And the main thing is to explain in details about that it will be different, but wait a little bit, and you will like it. Half a year, I don't know, in a year, it depends on the etiology and the duration of the deafness, of course.
Yeah, thank you. Rudolf, how do you approach patient? How do you counsel them from the surgical perspective as a surgeon? Yeah.
So that she told us all the correct things. That is really important, very important, to keep the expectations low, because they have never the same hearing like in the other side. But if you have a good counseling, then the patient afterwards, if he accepts that it starts a little strange and it takes more and more time to adapt, then the acceptance is much higher. But this is the crucial point. Keep the expectations for the results shortly after CI as low as possible.
Okay, good.
So thanks, Gunesh. He gave me a very special topic to discuss, the electrode conundrum. Does electrode selection significantly impact functional binaural outcomes in SSD, or is it primarily a surgical choice? So, difficult question. But let me first start with our hearing counseling tool, because we invested a lot of time to set up this hearing counseling tool. And as you can see here, there are 4 different topics. And we started with the single-sided deafness solutions, because in our opinion, this was quite easy to create this counseling tool. And fortunately, the number of users is growing instantly. According to Peter, he told me that. But let me ask to all of you, does everybody know about this tool, and has everybody used this tool? Hands up. Yeah, at least a few. This is nice, Peter, to hear. So there are the 4 pillars in counseling: no treatment, cross-hearing aids, bone conduction solution, and cochlear implant. And what is also important, we found a consensus on a diagnosis and pre-treatment before CI in single-sided deafness. And if you keep to this consensus, this takes a lot of time, because you start with the cross-hearing aids, you start with bone conduction solution, before you then finally do your cochlear implant. And of course, cochlear implant is the only solution which is restoring the hearing. And we also listed the benefits, the different benefits from audiological aspects as well, medical aspects and patient-reported aspects in this counseling tool, and also the drawbacks in all these aspects already told. And there is a number of references which makes it easier for you to refer to these decisive papers. So we looked into our own data, especially in children, usefulness of cochlear implantation in children with single-sided deafness. And fortunately, we found out that cochlear implantation benefits speech recognition in noise and sound localization ability in children with SSD at different ages. And all implanted children are full-time users regardless of age and duration of deafness before implantation. But coming back to the question about the electrode, in our group, all children were implanted with long electrodes, that means 28, or the flex standard electrode. But this is our data. And now I went to PubMed search. Is there any hints on length of electrode in single-sided deafness? So I entered single-sided deafness, cochlear implant, electroacoustical stimulation. No one hit. Single-sided deafness, cochlear implant, electrode length. No one hit. And I reduced to single-sided deafness, cochlear implant, electrode, and finally ended up in 30 articles in reviews, which came to the same result. CI is better than other procedures. Of course, this is a clear result we all have. But there was no one discussion on the electrode. So let's conclude this question. Due to the limited numbers of patients per SSD study, a comparison between electrodes was not in the focus yet. That is not in the focus yet. And looking to our hearing philosophy of complete coverage is highly recommended in single-sided deafness, especially if there is a complete deafness. And third, the recent advances in Otoplan should be used for an appropriate electrode selection, because we have now fantastic possibilities to find out the best electrode, as well as to use Otoplan also for an optimized ABF in single-sided deafness. Of course, there are further questions for clinical research, for example, different sizes of cochlear, and let's continue discussing.
Thank you. Thanks for Professor Gunesh giving me the chance to talk about this topic. The topic is, are the current minimal candidates requirements for the SSD cochlear implant sufficient, too restrictive, or unnecessarily broad? Sorry. You sorry. This,
You have to use this one.
this
There you
one?
go. Yeah.
Yeah, but
Yeah.
I lost my
No.
slides.
No.
Yeah.
You go. There.
Oh, yeah.
Yeah.
Thank you. Yeah, let's see the U.S. FDA approved for the adults and the children, means 5 years old, then can be selected for single-site deafness cochlear implant. And we see 2009 for model, 4 frequencies, the PTA more than 90 dB. But for Cochlear company in 2020, the 4 frequencies more than 80 dB HL. The two concept is different. And what will you do? What will you select it? This is the factors that we should think about. The first is age. When age of implantation, how old is the children is available for the cochlear implant single-site deafness, and also duration of the hearing loss, the other selections, and you guys can give me the reference. Also for C&D, very young children suffering from single-site deafness, but from the CT scan, MRI scan, we know this is C&D. What will you do next? Let's see the age. Earlier implantation, early can get best results. But for this, we know cochlear implant in children with congenital single-site deafness is most effective when performed before 3 years of age, leading to a significant outcomes and benefit. Implant after 85 years old, considerable reduced outcomes. We learned from Germany. And young children who received the cochlear implant achieve more symmetric hearing than older children. Through special hearing challenge remain for all from Canada. Canadian, we know this. And early cochlear implant children with prelingually single-site deafness associated with normal development of gamma skills. And short duration of deafness are high daily devices use were the key facts for better outcomes. And also, let's see the duration time. The impact of auditory deprivation during on cochlear implant outcomes in cochlear implant patients with cochlear remains unclear. Let's see. Speech perception scores in single-site deafness patients are negative, correlated with duration of deafness from American doctors. A long duration of deafness, more than 10 years, led to poor speech perception outcomes. And a retrospective study of 66 adults single-site deafness found no associate between the duration of deafness and cochlear implant outcomes. No significant associate with found between duration of deafness up to 40 years and speech perception outcomes in single-site deafness adults, suggesting that prolongedly auditory deprived alone should not contradict implantation. So in near future, let's think. For children and patients with prolonged hearing loss, which year should be okay? Assessment of auditory paths involved brain functions such as frontiers, EEG, ERP, etc. Thank you.
Thank you. Thank you.